All right, so we are live. Good evening. This is United Medical ACO Wednesday Wellness Webinar. I'm here with our program directors and our guest speaker. My name is Kemal Erkan. I'm the chairman of the program, and Amy Wilcoxon and Donna Gunkel, they are with me here. Donna is having a little bit of technical difficulties, but she's with us. And I don't see Caroline anymore. I think Caroline left us. There she is. So, all right. So, and our guest speaker today is Dr. Gary Singh from Delaware Cardiovascular Associates. He's a cardiologist, and he has been in our sessions a couple more times before. So I'm gonna open the session. All right. Okay. So, Amy, if you would like to introduce our others.
So Dr. Hundle, so I'm Amy Wilcoxon, dietitian, diabetes educator. Dr. Hundle is the chair of our diabetes program with First Aid Endocrinology. Tim McHugh is the physical therapist that we work with as part of SOS. And our social worker, who is part of our team, is Roxana Portlock.
All right, and then Caroline is our new member. So Caroline, how are you doing? You're on mute.
Doing well, thank you.
All right. So now, Amy, where would you like to start?
So we have, if you've been watching for the past year and a half or almost 2 years, our Wednesday webinars where we talk about all different aspects of diabetes, how it affects your heart, your kidneys, your mental health, your feet, eyes, and more. So tonight we're returning to cardiology. Dr. Singh, as Kemal mentioned earlier, thank you for joining us, talking about heart health and how diabetes doesn't just affect eyes and things we think about, but also very much can affect your heart. Thank you, Dr. Singh.
Thank you, Amy. Glad to be here.
All right, so Dr. Singh, I guess we can start with your part.
Sure. Thank you, Kemal. Good evening. I have spoken about this before. There are always new aspects, new things to speak about. Diabetes and cardiovascular disease go hand in hand. You know, to me, it's not a disease of blood sugar. To cardiologists, it's a vascular disease, and we treat it that way. We've gotten more and more involved in diabetes care, as I will talk about, due to certain new medications that are now affecting the treatment of heart disease as well as diabetes. Important to keep in mind that even though the picture you see up there is of plaque in a coronary artery, diabetes is not just about coronary artery disease and heart attacks. Obviously, strokes, congestive heart failure, renal vascular disease, peripheral vascular disease, and many other areas are affected. Amy, can you move the slide on? Thank you. These are truly, truly alarming numbers. When you look at the epidemiology of diabetes in this country, the rise is incredibly alarming. And as you can see, in a few short years, and honestly, maybe I'm getting old, but 2004, 2000, I don't know, I'm getting an echo.
We should be good.
Okay. I don't know, 2004, 2012 do not seem that long ago to me. And you can see the drastic rise in cases. Right now, give or take, depending which data point you look at, there are over 37 million diabetics in this country. That's diagnosed and undiagnosed. Now, I'm not speaking that's of prediabetes. This is everyone with a hemoglobin A1C of 6.5 and above. Prediabetes is a whole different aspect that we can touch on later. But keep in mind, again, as I said earlier, diabetes does not exist in a vacuum. It affects every part of your body, and most prominently, the vasculature, the heart, and that's the reason I'm here tonight. Amy, if you mind, the next slide. Thank you. Just some facts to brush up on. Diabetics are 2 to 4 times more likely to have a heart attack or stroke than non-diabetics. Much higher risk of congestive heart failure. Congestive heart failure is one of the top causes of hospitalization in this country. Congestive heart failure has a very high 5-year mortality. Heart disease tends to be far more severe. Vascular disease tends to be far more severe in diabetics. There's a higher risk of amputations, limb ischemia, and so on. Diabetes causes nerve damage in the heart, which can make a heart attack seem painless or silent. So diabetics may not present with chest pain. So in our practice, we remind all diabetics that even things like increased fatigue, shortness of breath on exertion that is not usual, decreased exercise tolerance. So let's say someone is able to walk 1.5 miles, and all of a sudden they walk about 1 mile and they're getting short of breath or winded. Don't ignore those signs. You can say, I'm having a bad day, but if it continues to occur, it's not because you suddenly got older overnight or you're having several bad days. It could be something going on with your heart. It could be a manifestation of cardiovascular disease. We all know about cholesterol, and diabetics tend to have lower levels of HDL and higher levels of LDL. And HDL, we want more HDL because that is really what gets the LDL out of the bloodstream. And elevated LDL is obviously associated with more plaque formation and vascular disease. Amy? Can you move on to the next
Kamal's
slide?
advancing. Actually, Kamal's the one advancing.
Oh,
Just
I'm
to
sorry.
let you know,
Kamal.
it's not me.
All right. Thank you. The American Diabetic Association comes out with standards of medical care every year. 2022, they came out in January with standards. And basically, what they pointed out is that there are 4 pillars of diabetes management. One, obviously, is glycemic management, the one we're most familiar with. I would like to touch on that a bit more. It's a bit more complex because everyone thinks of hyperglycemia, but hypoglycemia is just as, if not more dangerous. So it's incredibly important to avoid those hypoglycemic episodes. And if diabetics find that they're getting more of those, if they wake up in the morning with their blood sugars running lower, they're getting them through the day, it definitely bears investigation and going to your physician and talking about it, because those hypoglycemic episodes can be incredibly dangerous in the long run.
And we did have a session, I believe, 2 months ago, right, Amy, with Dr. Handal?
Yes, we did. It was back in February,
Yeah.
I believe.
Touched on hypoglycemia. Good. And so just to keep that in mind, there are actually incredible tools out there for glycemic management now. You know, everyone is used to the finger sticks that we've always done, but continuous glucose monitors have changed the whole terrain of diabetes management. The biggest issue seems to be getting them approved, but if you can get them approved and speaking with your endocrinologist or a family physician, internist, it's a good place to start. It's a great way to find out what your triggers are for elevated glucose. We find CGMs, or continuous glucose monitors, to be an incredible tool. The 2 most common ones out there are the Freestyle Libre and the Dexcom. And this way, you'd be shocked at what's raising your blood sugar and what isn't. You may be more sensitive to some carbohydrates versus others. There are things you think may not raise your blood sugar, such as certain proteins or milk-based products, and they are raising your blood sugar. So that's an incredibly important thing to know, to be able to manage the blood sugars and try to get them under control. Blood pressure management obviously is incredibly important. And we know in diabetics, there are certain medications that we try to utilize for blood pressure management, because what they do is they reduce the incidence of kidney damage, reduce the incidence of proteinuria Protein in the urine is a hallmark of kidney damage. And we know that certain medications, specifically they're called ACE inhibitors, angiotensin receptor blockers, do a great job of limiting that kidney damage. Lipid management, again, the goal for diabetics, per the guidelines, is to get that LDL down to 70 or below. Most diabetics do not meet that goal. So it's incredibly important, again, to keep an eye on those numbers, to work with your physician to get those down and take whatever steps we have to get them down. I do notice in my practice, a lot of people beating themselves up because they're eating well, doing everything right, but they cannot get their cholesterol down. Keep in mind that you may not reach there through diet alone. 80% of your cholesterol is familial, it's inherited, and there's just so much you can do with diet. You will make some reductions, but there's no reason to, again, beat up on yourself or be too hard on yourself. Sometimes you need medication to try to get those numbers down. And the medications we have out there are, the field is growing. We used to have statins. Now there's statins, there are non-statins such as ezetimibe. There's a newer medication called Nexlizet. We have injectables. We have medications that you inject every 2 weeks, which do a great job for people who cannot tolerate statins. And we are now coming out with a medication that is going to be injected twice a year. That is going to be given in the physician's office. It's called Leqvio, and that's out already, will be available very soon in the offices. That's a subcutaneous injection. Again, makes life very, very easy. It cannot beat a twice a year injection to lower your cholesterol. So there are more and more options out there, because statins are not always well tolerated. There's a small percentage of the population that doesn't tolerate them, but we have so many more options for them now. Also keep in mind, triglycerides are a target. When you look at your lipid panel, take a look at the triglycerides, make sure they're being managed. They correlate well with higher blood sugars. They are driven by carbohydrate intake quite often, and omega-3s are a great way to combat them. Fish oil, in addition to the other medications. Agents with cardiovascular and kidney benefit. Let's talk about that. Lifestyle modification, diabetes education is the foundation, obviously, and I think you guys have been hearing a lot about that. I know Amy talks quite a bit about that all the time, and that's where she focuses. And that is really the foundation of management. Kemal, can I have the next slide? Okay. There are two new groups of drugs, and I say new. In the past couple of years, we've really started to focus on them more and more. And you may notice that your cardiologist is not prescribing diabetic medications. You may ask, why is that? Because we're not prescribing them to treat diabetes. We're prescribing them to treat heart disease. SGLT2 inhibitors are recommended to treat heart failure in people who have weak heart muscles, and also people who have normal heart muscles but are hospitalized for heart failure, which accounts for about 30% of patients who don't necessarily have the weak heart muscles, but still wind up with heart failure. The medications that we know of right now are Farxiga and Jardiance. They are both approved for treatment of heart failure. And the Farxiga is actually approved in patients who are non-diabetic as well. That's how effective it is. The other medication group is GLP-1 agonist. The American Diabetic Association is now using that as part of their guidelines, strongly recommending that patients who have type 2 diabetes, who have already had a heart attack or who are at high risk of heart attack, be started on these medications, Ozempic, Trulicity, Victoza. Ozempic also is very beneficial in weight loss. Kemal, may I have the next slide? This just builds on what I said about the GLP-1 RAs, the Ozempic, Trulicity, and the potential areas where it affects. Atherosclerosis, diabetic atherosclerosis, high blood pressure. Obviously, by affecting that, it leads to a decrease in heart attacks, may lead to a decrease in heart failure. The data is not that strong on heart failure yet. That's why we're using the other drugs for heart failure. And keep in mind, these two groups of medications can be used together, and they work synergistically very, very well. in cardiac patients and in diabetic patients to prevent heart disease. Kemal? So the last thing I'd like to touch on is we talked about diabetes, is pre-diabetes. Pre-diabetes is something that quite often I don't think patients tend to take too seriously, because they'll say, okay, I'm not quite diabetic. I'm just going to go ahead and live with this. I can still go ahead and have some carbs and it's not going to bother me too much. Well, pre-diabetes obviously develops into diabetes. And even if it doesn't develop into diabetes, and you see that number, 93 million, that's actually an older number. The latest literature says there are 96 million pre-diabetics in this country. That's an awful big number. Because pre-diabetics, all of whom have impaired fasting glucose, impaired glucose tolerance, mildly elevated A1C, anything from 5.7 to 6.4 is considered pre-diabetic. Looking at 95 different meta-analyses of studies, and that's hundreds of thousands of patients, they found there is a higher risk of death, cardiovascular disease, coronary disease, stroke, atrial fibrillation, heart failure, chronic kidney disease, and also it's been found to have some bearing on increased risk of some cancers, which the data is still sort of weak. They're doing more research on that. And dementia, because dementia is a vascular disease. Because if you get microvascular involvement in the brain, you're going to be far more likely to develop dementia. So the key to this is, again, take the prediabetes very seriously. And we do tend to focus when the A1C is 5.7, 5.8, 5.9 to say, all right, we're going to try to treat this conservatively through weight loss, exercise, diet. And it does work, but involves a commitment. And you can't just say, I'm pre-diabetic, hey, I can live with this, I'm not diabetic, because it is having an effect on the blood vessels everywhere in the body. The exercise, which I didn't touch upon too much, is an incredible adjunct to diet. There are studies that have shown that taking people who are taking diabetic medications as they exercise can actually increase the level of medication. Decrease the level of medication they have to take. So remember, keep in mind that the primary consumers of glucose in the body, number one is the brain, number two is muscle. So if you exercise and you build up muscle, specifically resistance exercise, you're going to utilize that glucose. That's all I have for now.
Dr. Singh, you mentioned that you have dementia in the cardiovascular group. Do you mind just elaborating that a little bit? Because a lot of patients a lot of elderlies who are actually going through those types of issues, and it's becoming more and more common.
Yes.
But I mean, hearing it directly from you, it puts a different perspective, at least from our side. As you know, we do case conferences every day. And then when we have dementia, usually we associate that with the behavioral health side and not really thinking this part of it. Do you mind just elaborating that a little bit?
Again, I look at everything through the vascular lens, because that's the specialty that I'm in. Dementia is a vascular disease. There is an entity called vascular dementia. So just like we have ischemia in the heart, ischemia is a term meaning less oxygen delivery because of damage to the blood vessels. We have that ischemia going on in the brain because as the blood vessels going to the brain are damaged, the microvasculature, you're going to get less and less oxygen delivery. And if you look at CAT scans, you can actually see areas of damage. We call them microinfarcts. Infarct is basically, we call myocardial infarction as a heart attack, brain infarcts a stroke. Microinfarcts, almost a way of looking at mini strokes without having a lot of symptoms, except over time they build up, and that hence resulting in dementia.
Thank you. Now the other issue, and I know if Donna didn't have technical difficulties, she was going to join me, but
can you hear me?
Yeah.
Hey, there you are.
So, what's amazing to me is when we go through the case conferences, we pick patients, not randomly, but those patients who may be already high risk. And in some cases, they may just be there just because of their age. And the top three issues that we see is the diabetes, cardiovascular, and the morbid obesity. And usually these are not just single disease, they are all coming all together most of the time. And I would think that on the annual physical, when patients have their annual wellness visit, they will get a full blood work. Because in many cases, when we work with our nurses, the first thing that we look at is the A1C and see if this, and if A1C is high, and if there's any prior data, or then is it ordered again, so then we can actually keep track of what's happening. Many people really don't take it seriously from the patient standpoint. And that's kind of like really interesting to me because, well, actually it shouldn't be really interesting because my mom, who kind of picks up her medication on and off. So, but, she's controlling it, she's fine. But I think it's really just more and more, every day we see more of these problems. And I think the biggest maybe help is early detection, and then if we can actually diagnose them earlier, so we are, or actually getting the specialist intervention earlier. So sometimes I see primary carers, they're kind of like waiting on the patients. Instead, like the clinical integration is our core, and from the multidisciplinary approach, we want to see our endocrinologists, our cardiologists on the case earlier than in the typical traditional setting, because the outcome is a lot better in those cases with the patient. Absolutely. So that's what we are trying to promote, and these activities do also help us to learn more and emphasize some of these things more.
Well, and Kemal, I think I'm sorry. Go ahead.
Well, I was going to say, that was my question, though, to Dr. Singh, is when a patient has diabetes, is there a particular point or guidance you can give us on when we should get a cardiologist involved to see the patient?
I think it depends on concurrent risk factors, obviously. If you're a hypertensive, you're a smoker, you have a family history, you get involved pretty early at that point, that we should already be involved. I think pretty much most of them with a family history, we should get involved early. I think pre-diabetes is the time to get involved. That's the reason I included that last slide. And by the time you reach diabetes, you've already done a significant amount of damage. By the time that A1C is up there, you already have reached some level of vascular damage. If we can catch people early at a level of 5.8, 5.9, 6.2, that's great. I mean, that's when we want to start working on them, make sure they don't have anything underlying. And that's probably a good time to also, sort of take the, sometimes you have to use the scared straight approach, just talk to them about all the potential complications if we don't take care of things right now.
And I think that's, go ahead.
I was going to say, and then and nothing, the scares patients more than saying, hey, you need a heart doctor. So.
Right.
And I think too, to your point about dementia is, I'm sorry, cat's in the way. When I talk about heart disease and with the A1C and the link between A1C and your risk of a vascular event, and sometimes it's just, they've heard it. But when I talk about dementia, they take it. So there's different populations. Yeah. I know there's some I can talk about losing their hair. There's some I can talk about different functions that they care about. But dementia is one that they don't care about having a heart attack, but they care about having dementia. And I don't want to say they don't care, but it could be that they've heard it before. And so it's just sort of old news.
Well, I also think a big part of that is when you talk to patients, they say, but I feel good. So I think a lot of it is just like with medications, right? They don't go pick up their medications. They stretch it out for months. Kemal mentioned earlier, we see it a lot of times where we're kind of gauging when they should have had the next refill. 3 months, they got a 3-month supply. They should have picked it up in February. We're now in April, we're in May. They're not taking the medication. And so do you think that's a big part of it? Like when they feel good, then they don't think anything's happening to their body, but really it is, right? It's a buildup. I think you mentioned earlier, it's a buildup, and we don't want them to wait until it gets to that critical point.
I couldn't agree more. I think that we see it all the time in the practice. I mean, it's a tough one to deal with because when patients feel fine, it's the same way when we see patients in the hospital. When they start feeling good, they want to leave immediately, and there's no reason to be in there. And they don't want to see a doctor when they feel good. They come see the doctor. We have them in our practice when they feel ill, when they wind up in the emergency room. It's tough to do that. One of the tools that we utilize is I try to encourage them to bring in a partner, because sometimes if you can go ahead, if I can't push them, if Amy can't push them, then the partner will sometimes say, hey, you know what, wait, I want you to stick around for a while, okay, and take this seriously. Beyond that, you're absolutely right. That's a significant issue. It's very tough to get somebody with an A1C of 6.2 who's a construction worker and smoking half a pack a day, says, I feel great, man. I got nothing wrong with me. Okay, but you want to tell them that 5 years from now, you're not going to be able to feel your toes, but they don't want to hear that.
Well, and you're right. We get that, and we get that a lot. Well, I didn't feel anything. I said, well, you won't feel anything. And there is research on people who go by feel for their blood sugar. They say, well, I only I know when it's low or high, so I don't test. And Dr. Singh, your point about CGM, which we're really pushing, we're actually doing a study in QI on them this year because people are able to see, I'm seeing weight loss with CGM because people say, oh, look what happens when I eat something they like milk that they don't really think makes a big difference, or a big bowl of cereal, just because it might be healthier doesn't mean or maybe it's not as healthy as you think it is. Doesn't mean it's going to affect your blood sugar.
They're an incredible tool. They really are.
So we started, Dr. Singh, templated emails for some of our patients. And you may actually already get some feedback from your patients. So we divide the A1C level into two, anything less than 9 and anything over 9. So they get 2 different types of emails. And every time we go through those in the case conferences, we do actually make sure the patient receives some electronic communication from us. And on top of that, we also have the support group email going out to them. As you know, once a month we do the support group for patients with diabetes. So there's a lot of resources out there, and then we want to make sure that our patients can benefit from what we have.
Absolutely.
So Amy will continue with your part.
You ready for my part? I don't know if we had any more questions for Dr. Singh.
Well, I did not have any more questions. So
I'm here if you need it.
Maybe at the end, if you have we may remember some.
Okay, so
If I remember something, yeah.
I'm always lecturing, as some people say, about fiber. So I decided to talk. Well, I am going to talk about fiber because it's my favorite thing. You hear me talk about it. It's so good for you. But I decided to do some different research. So looking at some different studies, low fat, low carb, Mediterranean diets, and the effect on heart health and diabetes. So if you could move on, please. Thank you. So large studies on a low fat diet. And so when we think about low fat, we think about the 90s, and people were restricting to 20 grams of fat a day. That's not actually what we're talking about for your heart. So we're talking about your total fat, 25 to 35%, but low saturated fat. So people think about, low fat diet. I remember that in the 90s, and I ate Snackwell's cookies all day and pretzels, and my blood sugar got worse. But that's not what we're talking about here. So we're talking about beans, fruits, vegetables, lean proteins, and limiting your saturated fat and your trans fatty acids to less than 1%. So certainly the research for heart health, the TLC, the therapeutic studies consistently recommend low saturated fat, low cholesterol, low trans fatty. A low carb diet, which because I always push fiber, I sort of cringe. But if we look at where low carb, where it's considered to be beneficial, is as low as 30 grams, which to me is too low for most people, to 130 grams, or about 45%, no more, of calories. And these were found to be most effective actually for weight loss, changes in triglyceride and HDL. So not as effective for LDL, which is your bad cholesterol. The very low carb diet, so what we see with keto, 5 grams a day or less, were not found to be beneficial. Questioning lack of fiber, which we know is very good for heart health. Excess protein, people think, and Dr. Singh alluded to this earlier, I might be eating a lot of protein, it's not going to raise my blood sugar, but it actually will. And we know that it causes insulin resistance. If you are, and then when we think about heart health, if you're eating very, very low carb, what else are you eating? If you're eating lean chicken, it's still chicken. So you're still getting some saturated fat if you're eating a lot of it. So likely eating, because if you're not eating carbs, you have to be eating protein or fat. So that is likely the link with very low carb diets not being beneficial. With the Mediterranean diet, 40 to 50%. So higher total fat, but still very low saturated fat. So you think of the diet of that region, there's not a lot of animal products. So if you've ever seen the Mediterranean pyramid, really the animal products are at the top. So unrefined cereal grains. So think about what that might mean to you. In the United States, we might think about Cheerios, but that's not necessarily what we're talking about. We're talking about bulgur, kasha. So things that are very low processed, they take a long time to cook. They have protein naturally in them, vitamins and minerals and fiber, slow to digest, protective of the arteries, and good for blood sugar. Yogurt, cheese, fish, very limited red meat. So the Mediterranean diet, which if you've seen your cardiologist, a lot of cardiologists recommend it. We'll see what Dr. Singh has to say at the end if he has positive or negative. So it has been shown to all cardiovascular risk factors across the board and A1C. I do want to note about the Mediterranean diet in this country. A lot of people think of Olive Garden. So our pasta, white pasta, Alfredo sauce is not the Mediterranean diet. So that you just want to get out of your head. So certainly room for pasta. I don't want to pick on that. But when we think about beans, so think about chickpeas, think about vegetables, again, the cereal grains. So not fettuccine Alfredo. And then the DASH diet, which is really used for hypertension or blood pressure. But certainly, as Dr. Singh talked about, that is a part of heart disease. So the DASH diet, which is dietary approaches to stop hypertension, is low sodium, which is mainly watching your processed food. It's the reduction of meat, sugars, and refined carb, and eating more potassium found in fruits, vegetables, low-fat dairy, and nuts. So you think, well, what does that have to do with A1C? Those are all foods that are good for blood sugar, and you're also protecting your heart health by protecting your blood pressure. Next slide, please. Kemal, thank you. So items to highlight, some things to think about. I talked about fiber. So how much should you be eating? So if we talk about GI health, we talk about 25 to 35 grams per day. When we're looking at heart health, 20 grams or more per 1,000 calories or 40 grams a day. They have found, a lot of people tell me, well, I take Metamucil, I'm good. It's good for your gut, but it's not going to do anything for your heart. So you need to eat real foods that naturally have fiber, fruits, vegetables, beans, oats, bulgur, all of that kinds of things, all the things you see in the picture. Polyphenols were also particularly which are a phytochemical found in foods, particularly in berries, tea, coffee, cherries, blue and purple foods. So you think about like eggplant, red cabbage, cherries I already have up there. So those foods were also found to be protective of the heart. And if I could have the next slide, please. A few more items to highlight. The lycopene, the tomatoes and watermelon particularly, and a lot of people I see, well, I can't eat watermelon because it raises my blood sugar. If you have a CGM, you might notice that. But if you eat a cup of watermelon and you eat it with your meal, some protein and fiber, you should be okay. Watermelon should not be off limits. It's delicious, but you can't eat a whole watermelon because it will raise your blood sugar. It's a very good source of lycopene, which is very good for your heart. Interestingly, with lycopene, it's more available cooked. So while watermelon is an excellent source, tomato sauce, canned tomato products, because it's concentrated, it's even better source for you. Just watch the salt in the canned tomato product. Our last one is fat. Could you go back? Because I didn't talk about the fats yet. Thanks. So ALA, EPA, DHA, so fatty acids, flaxseed oil, walnuts, soybeans, tofu, olives, and olive oil. Omega-3 fatty acids, Dr. Singh talked a little bit about these. These are very protective for your heart. They help your triglycerides. They help keep those down, and they help with good blood flow. And we also find they're good for blood sugar. So good all around. Now the next slide, please. So what do we have to limit? I always like to talk about adding first. So before we get to the negative side. So the saturated fats, processed meat, so the skin on poultry, fatty cuts of meat, so beef, pork, lamb, anything that's processed, red meat particularly, but processed meat, bacon, salami, pepperoni, bologna, those types of foods. Sugar, so refined carbohydrates. So if you think about crackers, pretzels, donuts, cakes, cookies, all those things we like to eat. We can't eat them all day. We know that. And then salt. You have to read the label on processed foods. So if you look at this food here, 460 milligrams. We do need to have some sodium. You need about 600 milligrams a day. It's an electrolyte. Most Americans eat 6,000. I think the last thing I read was the average. So a piece of bread's about 200. If you go to Wawa and you got a hoagie, you're looking at maybe 1,500 milligrams of sodium in there. The bread itself is a fair amount. So anything that you get out, anything that gets processed has salt. So you need to look to see if you're eating a turkey sandwich, the bread has salt, the turkey has salt, it's got cheese, that's going to have salt. So paying attention to see where am I in my day. If that's my lunch, I should have a less salty dinner to go with that. That may be my last one, Kemal, I'm sorry. Oh, nope, that was my last one.
So, I was just looking at some of the new data with the morbid obesity, actually, again. So, especially in Delaware, I believe we are either number 3 or number 4 in the country. But one of the obesity with the associated comorbidities, illnesses, hypertension is about 36.4%, and then for high cholesterol is about 35.4%. And then with the adult diabetes, that's about 13%. So this is what I was saying earlier. So these diseases, they have this close friendship. So they don't like being by themselves. So they're always with another disease. And in many cases, it's a preventable issue. But I think we are just sometimes we are not taking the right approach. But hopefully, we can reach out to more people to get our message to them, hopefully. Any questions for Dr. Singh or Amy? So, Donna doesn't have any questions. Amy, you are okay?
I'm okay.
I was just going to ask Amy if she wanted Dr. Singh to comment about the Mediterranean diet.
Oh, yes. So they always say, my cardiologist said I should follow a Mediterranean diet. But pasta is really high in carbs. That's what I hear from my patients. I say, I don't think that's what he was talking about.
Yeah, unfortunately, a lot of people think of Mediterranean diet, they think of exactly what you said, which is, I'm going to go out for an Italian meal, have a bunch of pasta, a roll, and the breads, the part that they don't focus on is the unrefined grains.
Mm.
You know, and unfortunately, most of the grains in this country that everyone eats are refined. 15 or 16%, I think, of grain consumption is refined grains in this country, if I remember my statistic right, the last time I looked at it. So, and I think that's where the focus has to be. I do see a lot of that. It's a great diet. It's, first of all, the reason it's such an amazing diet is because it's not restrictive at all. It's not anything where you have to really focus in. I can only eat a certain number of calories. I can do. It's very easy. Just about anybody can follow it. You just have to eat certain groups of foods. You know, we get countless questions, I'm sure you do, Amy, about different diets, Optiva diet, the Noom diet, the Golo diet. I mean, all these different things every day that we're getting. And and the problem with that is that, first of all, the problem is the word diet. You know, the word diet implies something you're doing temporarily as opposed to a lifestyle. Whereas the Mediterranean, there's more of a lifestyle. It's the way it's the way everybody in that part of the world should be, is eating. It's the way we should be eating. Whereas certain diets set you up for failure because the moment you stop doing them, you bounce back, and nothing is more discouraging to patients than have that seesaw effect. You lose 25 pounds, suddenly you gain back more, and now you really are disheartened, and it takes so much more effort to go again. So, you know, long answer, but the effect is the same, which is just people have to focus in on it, except they pick and choose what they like, and they may have a different idea of the Mediterranean diet in their head. So you really have to kind of explain it to them and focus on certain aspects of it.
And it's a good point about being more of a lifestyle, and the way when you look at the blue zones and the way people are eating, that it's very relaxed and things are not measured. And I get so many people who say, I can't have carbs now because I have diabetes. And because just what you said, that's what they know are refined carbohydrates. You say, but no, I want you to have carbs. They're really good for your heart and your brain. And then we have to explain, maybe we're not thinking about the same foods right now. And then they may be some foods they've never had before, which has been difficult.
And unfortunately, marketing, you know, works against us. You know, people think Cheerios are heart healthy, you know, because they have that on the label. Snacking, everyone thinks of, again, going back to carbs as opposed to nuts, seeds, and so on. But everybody's still going for chips and pretzels. And it's interesting. I found that you can never assume that people know that already. I think you have to literally just lay it out sometimes. So we have shopping lists that we give patients.
Oh, I can't. He said, what's wrong with an apple? Why can't you have that for a snack?
Well, I mean, in many cases, people actually really don't know. And that's why I think making these sessions available, and even, like, I mean, I always say that even when I carefully listen what's going on, I always pick up some new stuff every time. So this is true for all of us, right? So sometimes we don't pay attention when we are in it every day. We think that we kind of know everything, but we don't. And I think just making it available and just keep repeating it is kind of the key. And hopefully people don't just Google their symptoms and then try to get some diagnosis and some treatment options. But if they do, maybe they will find us. So then they know to come back to the providers from that point. Well, Dr. Singh, thank you so much again. I know today was kind of like a late night for you, and you are already seeing patients and you are most likely on call. We really do appreciate you being available for tonight. And Amy, Donna, Caroline, thank you so much.
My pleasure. Come on. Thank you.
Thank you. Bye-bye.